We've got to design a system that allows us to demonstrate to our funders, federal government, and our friends over in the General Assembly, that we are using our funds in the most efficient and effective manner. One of the ways we're going to do that is to have an independent third-party assessment. We've already started those. That will allow us to allocate resources based on need in an objective manner. We want to have newer and more flexible service options and reduce some of the administrative burden from our providers as well as the agency. Y'all have heard me say this probably 6 times before, but I'm going to say it one more time. We spend an awful lot of time staring at paper up at DDS, which causes the providers to stare at paper and the parents and the families and the guys who get service to have to shuffle paper. And we'd like to spend that time doing fun things that are productive and measuring actual outcomes, as opposed to pencil whipping people down on whether or not they got all 75 forms in the right order. And y'all have got our providers have some excellent staff members, and we'd like to free them up and get them out from behind those desks, just like we'd like to free up some of our DDS people and get them out from behind the desk. This is a slide I think we've shown for the last 4 times. Remember in the version 1.0 we were talking about adults in service. That's about $300 million. Looks like about 7,000 people. We had 2 opportunities there. One was to do what I've already said, make sure we're efficient and it's needs-based, and to minimize the resources and time that as I've already mentioned. There's another component to this that involves what we call the halo spend. We've said from the beginning, we very likely will not save a big bundle of money in DD. We're not going to be able to do something magic and make the waiver go from $160 million down to $140. But what we can do is, if we get out of our own way, we might be able to provide some care coordination in a way that allows people to not utilize state plan Medicaid, reduce trips to the ER, reduce hospital stays, let people have a chance to be a little bit healthier. Y'all all know that that's where some big money is when we have our guys stay 3 days in the hospital where somebody else would have stayed 1, or that they have to be readmitted to the hospital because they got an infection because they couldn't follow the aftercare plan. Now, you see that halo spends only $45 million, and some people have asked us, well, Charlie, that's not very much. But you got to remember, this is just the Medicaid data. We still don't have the Medicare data, and many of our guys are dually eligible, so some of their medical care is over in Medicare, and we've got, at some point, we will be able to capture that data. I know Andy Allison, who's here today, our Medicaid director, has been working closely with our private payers and with Medicare to try to get everybody at the table and make sure this is a group effort. I've heard from some of my friends out of state who are amazed that we're able to pull that off in Arkansas, and I try to tell them it's all me, but they seem to think it's Andy. But y'all can make up your own mind. The dark things are things we think we've gotten close to the end on, or enough to darken. We know that we don't have all the details, and we won't until we start actually rewriting the manual, making applications to CMS. But we feel like we've got the fundamentals down on the assessment, certainly the target client population, the scope of services, which I'll review later, what a lead provider is. You've heard it called a principal accountable provider in some other episodes. We call it a lead provider. Under the health home column, some similar accomplishments. We know who we're targeting. We know what the activities are. We know what the provider participation requirements are going to be. You're going to have to be licensed or certified by DDS. The health home mechanics, we probably got a little ambitious darkening some of those squares. We put the payment model out. We know that it's going to be some payment based on performance. Some of that performance is going to be process. What did you do? Did you make sure everybody got to the doctor when they were supposed to get to the doctor? Some of it's going to be outcome-based. Did you manage to, overall, out of all the guys and girls you serve, lower their halo costs a little bit? We know we have to have a pretty robust IT system. You're going to hear me and Shelley say that 3 or 4 times today. A lot of the stuff that we're proposing we do is going to be centered around having a very good web-based IT care plan application, assessment and billing package, and we think we're going to get there. We've seen some good ones. We just got to, at some point, pull the trigger and get one. We still have to talk today about some of the episode mechanics, payment model, what performance measures, although to Shelley's chagrin, we never actually get down to it. I think you're bringing somebody in to help us work with stakeholders to nail those down. And then the implementation and administration.
The slide that I'm going to talk about is the recap, a little bit of a summary about each one of those 4 items. Assessment, we have CHMAC listed there. That's the IT system that contains the assessment, allows the assessors to put that information in. But it's been a whole lot more than that. If you've served on any of the assessment review committee and participated in any of these workshops, you know there were a whole lot of components to this. We worked with the University of Michigan. We selected an NRI tool. We had stakeholder input. And we have the system, and we have the Pine Bluff Psychological Associate Assessors. Assessments are happening. Now, I'm not going to minimize the fact that there's always some issues with the brand new IT system. I've advised somebody the other day, never ever try to develop a new IT system as part of a new program. It's been very difficult to get through all of the DHS security and get that to run smoothly, but they are happening, and we expect that project to be kicking off. As you'll see down there, as this first kickoff group, the folks over the age of 18 and over, not in school, institutional level of care, people already receiving services, human development centers, the small ICFs, and people on the waiver. It's about 4,500 people, and we also have a system in place. We have to work out some of the particulars about significant change, when people's status actually changes to a degree that it's going to be necessary for the assessors to come out and do a new assessment. We have a process that we're working on for that. A lot of training has gone into place so far for assessors, and we know that there's a point not too far in the future where we'll have providers and families in, maybe in a place like this, to hear more about what the assessment is, what the different areas mean, and what all this process will mean for us in the future. When we move down to the target population, we have two different episodes, if you will. The comprehensive episode, and we look at that as coming from 2 different directions. You would have the agency-directed, which is basically what we have now, as well as self-directed. We have good models for that in other divisions. The Division of Aging and Adult Services has a self-directed model that we have heard a lot about, and we hope to use their expertise to design this one for us. And then the expanded episode for folks eligible for DDTCS services only, those folks who are not at an institutional level of care. The episode definition, scope of services, all the episodes we're talking about will be 12 months. The comprehensive will include those I mentioned, HDC, small ICF, ACS waiver, DDTCS, and personal care. And in the future, the Community First Choice option will have some impact on that list there. Self-directed will be both comprehensive and self-directed, and the expanded will be those folks currently receiving DDTCS services in an expanded capacity, meaning that there will no longer be a requirement for those services to be clinic-based only, which will be a big improvement in services for people. Things that you could practice only in the clinic setting, you can get out in the real world and do. And as to lead provider, the lead provider receives this periodic episode payment. Lead provider ensures access to all services identified in the person-centered plan, identified in the assessment, are carried out, and if not carried out, if they don't occur, then they have an explanation in the plan of care why they didn't. And that lead provider also both achieves and reports quality outcomes. Community first choice option. We've heard a lot about this over the last few months, and it seems like at DDS it's about all we ever talk about is how are things going to be different under community first choice. It doesn't matter if we're talking about quality or eligibility or access or choice. We're all wondering how that's going to work when that happens. What is CFCO? It's a 1915 case state plan option for home and community-based services. This is important that it's a state plan service because you know, as if you have anything to do with the waiver as a family member, as a participant, as a provider, as a state agency or the operating agency, Medicaid, it's very rule bound because you're waiving that right to institutional services. A lot of rules to follow, a lot of processes, and this hopefully should be more streamlined. It does have a 6% permanent increase in the federal match rate. It's a lot of money. We looked at this for maybe a year before we ever decided that the benefit outweighed all of the transition problems that'll be from moving to from waiver to state plan services. It'll become the main program that comprises the DDS comprehensive episode, and it will cover all eligible institutional level of care clients, including those on the waiver wait list. So we think for 2,000 people who've been waiting anywhere from last week to 5 years ago, this is going to be a wonderful program. So where are we in that process? DHS is working in collaboration with the stakeholder group, the Development and Implementation Council. Anna, about how many people? 17, most of whom are consumers, family members, advocates. Some providers on that council. They've had one meeting already, another one scheduled for January. The holidays are coming. You know, we have to put off some of the business stuff to get through the holidays. And what comes next? The series of monthly council meetings. Of course, we also have an internal work group trying to align service descriptions, a lot of work going on inside the department. And the program will start simultaneously with developmental disability and long-term supports and services episodes in the first half of 2014. And, of course, that's just a little over a year from now.
Shelley talked a little bit about the difference between the expanded episode and comprehensive. And I know those are goofy terms. They don't seem to work right, but we were talking about the expanded episode is our DDTCS adult development expanded, and comprehensive is everything. And we may have to come up with a different word because we constantly have to explain expanded. But one of the goals I had going into this was for us to loosen up the restrictions associated with our day programs for adults. Right now, they can't leave the campus. It's very clinic-based. You can practice crossing the street inside the clinic, but you can't go outside and practice crossing an actual street. So we really wanted to get that done. There are some other things that go along with that. Being freeing services up to be outside the clinic that allow us to be expanded even further. We're not looking at expanding how much it costs. Andy frowns at that every time I bring it up. But we'd like to be able, for families and providers to be able to use that money that would go for a lot of sitting for some more, maybe more productive and fun activities. This is pretty much everything you can get on the waiver, including the adult DDTCS, which is adult day program, the evaluation and the service. Community integration, you notice, has a star there. That's going to end up being a pretty good sized category for us because we feel like that's the thing we want to promote. That's the thing I hear from families and providers, that if we could do a little more of that, people could get really creative in how services are provided. I'm looking forward to when we finally get to write that so we can make sure it's as comprehensive as possible. Some of these things at the bottom don't, as our McKinsey friends like to say, that's not much spend. But they're very important to the people who need them: crisis intervention, community transition, personal care, consultation. We have a lot of things in our waiver program now that when you do a graph of the spending, they're barely a blip. But when somebody needs one of them, they really need it. So we hope to include all those. You can see the ones in the expanded episode, which would mean folks who are DD, who are adults, but who do not meet the institutional level of care. And for y'all that don't know, that's a pretty low threshold for us. Anybody on the waiver meets institutional level of care. Obviously, anybody in a ICF meets it. But we do have a group of people right now that don't have quite enough need to get up into that. Couldn't have got on the waiver today, even if her name was number one on the list. Now, what we don't know is, and I talked to Andy about it a little yesterday, and we're just going to have to wait and see, is how many, if we do manage to implement Medicaid expansion in Arkansas, we may have another group of people whose income is too high to get regular Medicaid, but whose level of need is not so high that their institutional level of care. And since those people don't have any reason to present themselves to us now, we don't know how many that is. Could be a handful, could be a busload. We'll figure that out more as we move towards talking about Medicaid expansion and implementation of other parts of the ACA.